Okay, so let's start. Imagine that you have a 74-year-old brought in for an inability to talk, and her husband is very concerned, brought her into the emergency department. Her chief complaint is, I want to talk, but I can't. So right off the bat, there's a discrepancy here. She is talking and saying that she can't. And yet, she really does experience that she's having difficulty with speech. The symptoms had started the day before, so that gives you a bit of a timeline as to how long these have been going on. This would be considered acute. So let's stop here. As a point of reflection, what else do you want to know in terms of trying to figure this medical mystery out? What are the questions that are generated in your head? What else do you want to do in terms of evaluations, tests, laboratory analyses, physical exams? And where is your mind taking you if you're considering different diagnoses, different treatment options? Uh, is your mind already generating some options? That's just for the sake of reflection, but I'll continue with the story. In terms of the history of present illness, her core symptoms included the following. Uh, and by the way, most of the history was obtained from the husband who accompanied her. She appeared anxious and at times was unable to verbalize. She stated that she wanted to respond to questions, but her brain was in a quote whirl and she was unable to get the words out. During the interview, the patient was noted to be unable to verbalize at times, and occasionally, when distracted, the patient appeared to be able to respond. Her vital signs included a blood pressure of 181/98, so very high, systolic, heart rate of 86, respiratory rate 18, temperature 37.1 or 98.8 Fahrenheit, and O2 saturation is 95% on room air. So she was breathing okay, although a bit tachypnic, and her blood pressure was elevated. Her mental status was interesting. It revealed in bold there, in terms of appearance, that she was very anxious, depressed, and somewhat frazzled. She was propped up in a stretcher and groaning at times. Skipping down to the psychiatric components of the mental status exam, she was alert and oriented times three. She was anxious, especially when unable to get out the words, cooperative, but a bit frustrated during these periods of what we call aphasia, lack of ability to speak. She was depressed appearing. Neurologically, she really had no focal findings, so no major deficits, and she was moving all extremities, all four of them, against gravity, meaning moving them well. The husband revealed that patient also had some other symptoms. She had at times tried to go to the bathroom at night, complaining of inability to urinate. And sometimes the patient was walking with her, with him protecting her, but she'll immediately stop, thinking that she's about to fall over, and never did fall. No report of other concerning findings like fever, chills, sweats, or what we call diaphoresis, chest pain. She did report some palpitations or heart chest flutters, did have some constipation and take some laxatives for that, and had to take some Imodium also, or loperamide for that, uh, compliant with her prescription medication. So she was taking all of her usually prescribed medications. So again, another stopping point to reflect. What else do you want to know, right? What information would be helpful to figure this out? What else do you want to do? What tests, laboratory analyses, interview questions, physical exam questions do you have in your head? And where is your mind taking you? At this point, do you have any differential diagnostic categories, potential diagnoses, and potential therapy options? Moving on to reveal more of the story, the patient commented that she is very anxious and depressed. She is herself subjectively feeling that. Husband states for the past year or so, the patient has been very melancholic and cries over everything. Also thinks that she has been impacted by the death of two of her close friends, his own open heart surgery and lung cancer diagnoses. So he's been through his own medical issues, and also one of their son's illnesses. So a lot of stressors. States that the patient thinks that she has multiple illnesses and has undergone different tests, but some tests without any significant findings. So, patient really has been worrying about her illness quite a bit. Sleeping has been a struggle, although with Ambien or Zolpidem, she might sleep around 6 hours for the night, according to the husband. A little more history in terms of past medical history. She does have gastroesophageal reflux disease or GERD. She does have hypertension, hyperlipidemia or elevated lipids, anxiety, depression, psoriasis, psoriatic arthritis, and osteoarthritis. All of these are chronic conditions that she's been managing for some time, nothing new. In terms of past surgical history, she has bilateral total knee replacements and cholecystectomy or gallbladder removal and a C-section way back when she had a kid. Past psychiatric history includes, again, this poorly stated depression, anxiety, no DSM diagnoses that were offered times many years, managed by a primary care physician, not a psychiatrist, and has not really had significant psychiatric evaluations, and certainly no inpatient psychiatric care, no suicide attempts, no substance use, although has been smoking half a pack a day of cigarettes since the age of 20. So some nicotine use there for sure. In terms of family history, father had Alzheimer's disease and mother had essential tremor. Also has another sibling, it's unclear if it was brother or sister, with Alzheimer's. So as you take this into account, there's some genetic loading, some history here, some chronic conditions, and some note of psychiatric illness without clear uh, determination as to what the diagnosis is. In terms of her home medications, there are many. She had been taking, at the time of arrival, duloxetine, also known as Cymbalta, 60 milligrams twice a day, oxycodone, acetaminophen, or Percocet, 10 milligrams slash 325 milligrams every 6 hours. Methotrexate, 2.5 milligrams once a week on Fridays. Zolpidem or Ambien that I mentioned, 10 milligrams at night. Enbrel, 50 milligrams subcutaneously once a week on Wednesdays. Folate or folic acid supplementation. Amlodipine, olmesartan, Azor, 5/20 milligrams daily for heart and blood pressure. Propranolol or Inderal, extended release 60 milligrams daily as needed for anxiety. Alprazolam or Xanax, 0.25 milligrams daily as needed for anxiety. And clonazepam or Klonopin, 0.5 milligrams daily as needed for anxiety. So you can see a number of strategies here, pharmacologic strategies for anxiety that also have side effects and other concerns. So quite a bit of medication here. So again, more information has been revealed at this point in terms of stopping and reflecting on the case. What else, once again, do you want to know? What other tests, labs, findings do you consider? How do you obtain those? So what else do you want to do? And finally, where is your mind taking you in terms of differential diagnoses and considerations? A little more information in terms of objective analyses. Her complete blood cells count and her electrolytes, as well as her liver function tests, were all within normal limits. So nothing too remarkable there. Her thyroid stimulating hormone, TSH, CK, creatine kinase, her ammonia, her folate, and her C-reactive protein were all within normal limits as well. Her chest x-ray was also clean. Her EKG was within normal limits with a QTC of 434. Her CT of the brain, which is visualized here, was negative for any acute intracranial pathology, although it showed some involutional changes with volume loss. And as mentioned, no CT evidence of any acute pathology. So some involutional changes or age-related changes with a bit of atrophy or reduction in the size of the cortical mass was noted. But that happens very gradually, and it's not typically the reason for somebody to have sudden findings like this patient did. The urine analysis also showed, interestingly, some growth of Klebsiella bacteria. And as you can see, the findings there might suggest an etiology or a cause for some of these new symptoms. When consultation liaison psychiatry was consulted, or CL was consulted, we conducted an intake. And this is what we observed. I'll read most of this. The patient was seen at bedside with the husband, and interview was limited as at times patient was unable to verbalize and became silent through the conversation. Patient stated she has been feeling anxious for years now, which she relates to numerous stressors, including her husband's heart surgery, lung cancer diagnosis, and a son's health, as well as recent death of two of her very close friends. Patient stated that she's having a lot of free time and constantly worrying. She stated that her mood has been worsening in the last few months, stating feeling sad and that she's been crying every day. She stated sleep and appetite are, quote, horrible and always feeling tired. Patient also mentioned feeling hopeless, but is not able to elaborate as she becomes silent on the conversation. Patient is able to engage again with some redirection and support, and she denied any self-harm thoughts, passive or active suicidal or homicidal ideation. She also denied any auditory hallucinations, visual hallucinations, or paranoia. And the patient mentioned several times being concerned about different illnesses like Alzheimer's and being unable to walk. She also mentions that her father died from complications of Alzheimer's. And she finally mentioned having essential tremors that run in her family. So you can see pretty quickly it was ascertained many biological, psychological, and social variables that are affecting this individual at this time. So when it comes to the exercise of determining what is the diagnosis, it's important to have so-called differential diagnosis and consider many different options simultaneously, not exclude one or the other. At the top of the list, we have the possibility of an anxiety disorder that has never been properly diagnosed and is now manifesting in unusual ways with fear of walking, fear of talking, if you will, in relative periods of mutism. Another option is an adjustment disorder, which is a time-limited reaction to recent stressors. If somebody's going through, quote, a hard time, losses, deaths, challenges, they may have an adjustment disorder with anxiety and or depression. Another option here is a somatic symptom disorder in which somebody is very preoccupied with their physical health and diagnoses and are so preoccupied that they're they're experiencing functional impairments as a result of that. Chronic pain should be considered here as an important variable. This individual is taking Percocet every day, presumably for her osteoarthritis and psoriatic arthritis. And it's important to understand that chronic pain comes with biopsychosocial complexities. It's not typically just a condition about pain. Very often individuals have overlays of anxiety, depression, and all sorts of other challenges. Polypharmacy, or the interaction of various medications, is very important here. We saw a long list of medications, and she is of advanced age. Perhaps these medications are having interactions causing all sorts of issues in terms of impaired ability to speak, maybe some confusion, maybe some difficulty with urination, as described earlier, in terms of anticholinergic effects. There are many possibilities here, and these medications in combination may be catching up with her, if you will. There's also the possibility of neurologic disorder, meaning something that is brain-based, that hasn't been diagnosed, that is causing these freeze episodes, the mutism. Personality traits and disorders are always under consideration as possibly contributing to a picture. Is this individual particularly dependent? Is this somebody who's clingy, needy, if you will, at baseline and depends excessively on others, whether it's doctors, providers, her husband, etc. Delirium is an important consideration, also known as encephalopathy. Confusion caused by a medical cause. Catatonia is also to be considered. Catatonia is a condition in which individuals freeze up, become rigid, become mute, become immobile, and are unable to basically move and operate fluidly as they used to. So that is also a consideration here. And still others. It's important to remain as clinicians and providers open to the possibility of different explanations for this, whether it's medical, physical, psychological, social, spiritual. So these are all of the considerations that were swirling through the minds of the providers. Neurology was consulted by the medical team because they felt that actually one of the other considerations was possible psychogenic non-epileptic seizures. Now, this refers to, of course, not epilepsy, but seizure episodes or seizure-like episodes that are thought to be psychologically mediated. And so the medical team wanted to rule this out, wanted to exclude this possibility. And at face value, it seems like it's a bit premature to jump to that conclusion, but neurology was consulted anyway. They also consulted us, psychiatry, sort of urgently for this anxiety and panic. So you can see the primary medical team already being sort of biased towards a psychiatric or psychological explanation for the condition based on everything that we just reviewed, her normal CAT scan of the brain, her relatively normal labs, the fact that she's able to talk at times but not at others, which makes one think this is inconsistent and it's maybe even selective. The fact that she has a history of depression, anxiety, a number of medications on board, that she has stressors that maybe could be affecting her in a psychological way. All of this, perhaps understandably, influenced the medical team to think of a medical, or excuse me, psychiatric explanation. But labs and an electroencephalogram were ordered by neurology. And interestingly, we found an abnormal electroencephalogram or EEG in the awake and drowsy states. Something was off. 4 electroclinical focal onset seizures were recorded arising from the right frontocentral region. In other words, actual epileptic events were captured and recorded by the EEG, a brainwave test, arising from the right front part of the brain. Neurology actually started some medications, anti-epileptics known as Vimpat and Keppra, loaded the individual with that, and then changed over to a different one, Depakote or valproic acid, and were able to stop the seizures. And in subsequent evaluations, she also received an MRI of the brain and found same thing, parenchymal volume loss, some changes that came with age, but no major abnormal acute emergent findings. There's a lot of language on this slide, but I'll focus also on what's in bold. There was also this possibility of marrow infiltrative process, such as metastasis, which is, of course, what happens with cancer when it spreads. And the radiologist reading this MRI said maybe multiple myeloma, lymphoma, or other possible cancer cannot be excluded. And they recommended clinical correlation. In other words, follow this up, do tests, do labs. And they did, and basically found nothing else on other tests. This is the rest of the workup. They did a CAT scan of the abdomen and the chest. There was no evidence of cancer, thankfully, and also her hematologic or cell lines were okay. They consulted hematology for that. So we did not think that cancer was really at play here. And in fact, she improved dramatically. No further symptoms on the Depakote 250 milligrams every 6 hours. She was tolerating it well, too. And she connected with neurology as an outpatient once she was discharged, and she kept taking the Depakote or valproic acid. She did complain of some side effects and asking to come off of it, but that's a whole other matter. She did respond well to this and didn't have any further episodes of the talking freezes. So it was an important reminder of the differential diagnoses that cause speech arrest. This image here is a reminder of the different types of aphasia. Aphasia is a cessation of speech or an interruption of speech, abnormal speech due to a neurologic or other medical process. And you can see that the way us, doctors are meant to organize these is to think of what's called fluent aphasia, meaning is the speech itself being communicated clearly, or expressive aphasia, is the person not even understanding or receiving the information right, and can they repeat it back? And so you see all of these questions that we ask ourselves to then go down the algorithm or the tree to see which one of these might be the aphasia at play. Now, in this case, she actually wasn't diagnosed with a conventional aphasia because it was temporary and it was reversed with treatment. Instead, what we thought about with this case is what's called aphemia. Now, aphemia is a different, slightly different phenomenon than aphasia. And Broca, who's pictured here, is a very famous physician who described aphasias, but also described aphemia. Aphemia is something that most physicians actually don't think enough about. Most physicians do learn about aphasia and Broca and what part of the brain, this is termed Broca's cortex, or Broca's area, what part of the brain is influenced or impacted in aphasias. But aphemia is a different matter. And I'll just quote what Broca wrote a long time ago. Basically, he described that there are cases where the general language faculty persists unaltered, where the auditory apparatus is intact, where all the muscles, not even excepting those of the voice and those of articulation, obey the will, and yet where a cerebral lesion abolishes articulated language. So that's a lot of speech to say everything seems intact and yet the person's unable to talk. This abolition of speech constitutes a symptom so singular that it seems to be useful to designate it with a special name, aphemia, or a deprivation of speech, speech. It is only the faculty of articulating words that these patients lack, right? So they're thinking of the words and they're unable to sort of articulate it. They hear and comprehend all that one says to them. They all have their intelligence. They emit vocal sounds with ease. They execute with their tongue and their lip movements much more extensive and energetic than those required for the articulation of sounds. And yet the perfectly sensible response that they would want to make is reduced to a very small number of articulated sounds. So this is a long way of saying that the individual is really trying hard to communicate what is in their mind. They know what to say, and they just can't get it out. And it's kind of like having words at the tip of your tongue, but instead, when you're struggling and you have words on the tip of your tongue, you can't quite imagine the word. In somebody with aphemia, they do imagine the word. They know what they're trying to say, and they just can't get it out. So this creates a lot of clinical confusion for physicians, doesn't it? If somebody comes in and can't speak. And frankly, there have been reports, like the ones I'm showing here, of individuals who have had aphemia, which is arguably rare, and it being confused for other things. For instance, this was a case that was published of somebody who had, once again, frontal lobe epilepsy, what's called non-convulsive, so not shaking, status epilepticus, or uncontrolled epilepsy. And the person had stuttering, had aphemia, and some aphasia, so it was mixed. And it was not a sign of what we also call psychogenic non-epileptic seizures in other spaces. Remember, the patient was called for that. And in this case, I'm not going to review all of this. They described an elderly man who experienced personality changes and bouts of stuttering, followed by anorthria with preserved writing, and then aphasia, and then some confusion. And the EEG there showed non-convulsive status epilepticus. Again, this is not physically shaking, so you can't see it. Uncontrolled epilepsy with focality, in other words, focused in the left frontal region of the brain. So it was very interesting. Another case of sort of focal or localized seizure activity that you wouldn't really understand or pick up unless you did the EEG. This is actually a normal EEG showing the brain waves at different spots emanating in the cortex. These are all different markers for where the electrodes or the wires go on the scalp. Wires are placed with a little gel on the scalp, and it measures electrical activity below the scalp and skull. And you can see all of these different placements in the brain. This is the EKG down here, electrocardiogram, that's done at the same time just to correlate activity, just to match it. And this is a normal EEG. This is from the article that we were just reviewing. When the individual could not get his words out, he had findings in the localized left frontal electrode. It says right here, cannot get words out. Later, he also couldn't name, write, but did follow commands. So he's able to receive commands and yet wasn't able to name right during that time. And then he became somewhat unresponsive, mute, confused. This is where electrical activity, as you can see, gets quite abnormal in multiple spaces. There's spreading of that phenomenon from just one or two electrodes to more. It just goes to show the progression of electrical changes in an individual. So that was from that case report. Another case report spoke about how later in life you can have some de novo or new aphasic status epilepticus, so seizure activity that is causing essentially speech problems. This is a report from 2022 in which they described this. They actually looked back at patients, and over about 8 years of practice in this group, only 19 patients with this aphasic status epilepticus had no lesions in their brain when they had full imaging done. Most of them were women, 71%, and most of them were of advanced age, 66 in terms of mean age. 6 died actually during these events. So this is a very serious condition. Like all seizure disorders or epilepsy conditions, needs to be taken seriously. It's an emergency, and you need to abort the seizure activity, give a benzodiazepine or an anti-epileptic drug right away if you identify that. It's interesting, persistent aphasia that sort of lasts longer than 65 hours, according to this analysis and other experts. If somebody is really having that difficulty of speaking longer than 65 hours, is likely that they could have this condition. It is rare, but it's a rare emergency. You wouldn't want to miss it. In terms of what aphemia looks like over time, there's a hint here that maybe it is correlated with some neurodegeneration, right? So changes in the brain. Brain is, um, involuting, degenerating over time, atrophying, losing mass, which is why you see it in older populations. This is a case report from 2011 where they actually followed an individual over time for many years. A 70-year-old male who initially presented with difficulty pronouncing and producing words. That was his first problem, was with speech. And over time, there was an associated degeneration of brain matter, in other words, dementia of some sort. As you can see, this brain really does have a lot of atrophy or black space in there where the cortex used to reside. In younger times, this would have been all nice and full and gray, but you see all of these black interdigitations, and that's because of the atrophy of the brain. And this was thought in this case to be a precursor to what's called apraxia. Apraxia is a failure to do various tasks, walking, talking, bathing themselves, eating, motor tasks that is seen in advanced dementia. So sometimes the earliest hint might be speech problems, and that's why it's important to attend to this. Not only because speech problems can be part of a seizure disorder, as we're talking about, but also can be the first hint, the canary in the coal mine, if you will, towards other signs of dementia. And these are images showing changes over time. The patient was imaged at age 75, and then was had another image 5 years later. That's in B, and then 1 year later. So 1 year after that, that's C. And so you can see the reduction in these highlighted areas. That's brain activity from what's called a functional MRI. You can see the reduction over time. Sadly, just as age marches on, the brain loses its spark, if you will. You can see a petering out, if you will, in terms of that brain activity. And it's no wonder, of course, that there would be changes in speech or in other activities. The case that I just described, I actually published in an academic journal, the Journal of the Academy of Consultation Leads in Psychiatry, as a brief report to raise awareness about this finding, aphemia, and to suggest that we should not jump to conclusions and say this is psychological or this is psychogenic. It's important to rule out all other conditions. In this case, the EEG was very helpful, of course, in identifying frontal seizures that were causing mutism. And so we published it with some of my colleagues that are listed there in order to increase that kind of awareness. And you're welcome to, of course, review the article on your own. This is an important task actually for consultation liaison psychiatrists. People might think that psychiatrists are really just there to quote shrink heads and label everyone with depression and anxiety, but actually we advocate for thorough medical evaluations. We advocate that no stone goes unturned, if you will, and that we exclude all of the other possibilities before jumping to conclusions. And in that way, paradoxically, we're actually more like medical sleuths, if you will, or investigators than traditional psychiatrists. So psychiatrists in the medical setting or consultation leads and psychiatrists really do something a little different in that respect. So in summary, speech changes can have many, many causes. If you remember that list of possible diagnoses and presentations, speech, in fact, is a very complex neurobiological phenomenon. We didn't even talk about volume and tone and rate and accent and all of these other components of speech. But when speech goes awry, many different things can cause that. It's important to expand the differential diagnosis when we do that, of course, and that organic or what we call medical workup, not just psychiatric considerations, but organic workup is essential, of course. We should trust our own awareness of what epileptic seizures are and what they aren't, right? So epileptic seizures are not just seizures involving people flapping around dramatically with their whole body shaking, or what we might see in the movies. Uh, that is part of seizures, right? Those are called grand mal seizures or tonic-clonic seizures. But there are other types of seizures that are smaller in nature that only impact speech or other areas of functioning. And it's very important to not forget those seizures that we sometimes call focal or partial seizures.